Hi everyone. Today's lecture will be on laboratory investigation in oral surgery. We will be talking on the indication and frequency for lab investigation. Next, we will discuss on the necessity for all this lab investigation. We will also talk on the category of the lab investigation, the diagnostic and the screening test, and finally we will discuss on the legal aspect of laboratory tests. Clinical laboratory testing plays an essential part in the delivery of quality healthcare. Lab tests has an acknowledged widespread role in clinical decision-making and therefore a role in determining clinical outcome. Lab tests are particularly useful in validating a diagnosis, predicting disease severity, and monitoring disease progression in patients with infectious diseases or immunological disorders. Timely diagnostic assessment and implementation of reliable tests are extremely important in disease management. In managing a case, a doctor will be attending to the patient's chief complaint. He or she will then take a proper history and then conduct the physical examination, run some specific tests, which is the lab test, and then formulate a differential diagnosis before comes up with a final diagnosis. With this final diagnosis, the doctor will finalize the treatment plan for this patient. So here you can see the lab test plays an important role in uh, in formulating the final diagnosis of the disease or illnesses before we can uh, offer a treatment to the patient. So lab tests can be classified into hematology, microbiology, biochemistry, immunology, histopathology, and cytopathology. Hematology deals with investigation of abnormalities of blood cells, their precursors, and of the hemostatic and clotting mechanism. Microbiology um, is a test to detect and identify the causative microorganism. For example, antibiotic sensitivity test. This is where the body fluids, the mucosal surfaces, and excised tissues are examined by using microscopical, cultural, and serological techniques. Biochemistry is also known as chemical pathology. This lab deals with investigation of the metabolic abnormalities of the body in disease state. Investigations are carried out by assays of various normal and abnormal compounds found in the body fluids, blood, urine, or saliva. Immunology, this is where the lab test deals with the detection of abnormalities in the immune system. The primary role of immunology study is to identify a disease by observing the presence of an antibody in the patient that resulted from the infection. Histopathology is a test which deals with the identification of structural changes in diseased tissues through microscopic examination of appropriately stained tissues, section obtained from biopsy. And cytopathology is a test which study the role of individual cells or cell types in a disease. In this test, cells are stained and studied under light microscope. So what are the frequency of lab tests used in oral surgery? The most frequently used lab tests in oral surgery are complete blood count, which include hemoglobin, hematocrit, absolute and differential white blood cell count. The bleeding studies, which include bleeding time, clotting time, prothrombin time, and activated partial thromboplastic time. Um, Peripheral blood smear is also frequently ordered. Random blood sugar or random blood glucose, renal function, and also histopathological tests. So these are the most frequently ordered investigation in oral surgery. Those occasionally ordered lab tests include tests for disturbance of bone, uh, for example, test for calcium phosphate or ALP. The erythrocyte sedimentation rate is also occasionally ordered. Screening tests for HIV and microbiological tests are occasionally ordered in oral surgery. Those tests that are rarely ordered include enzyme testing, bilirubin estimation, creatinine, acid phosphatase, blood urea and nitrogen, and immunology tests. So next we will be looking at the indication of lab tests. Lab test is indicated in order to confirm the diagnosis of the disease. Some of these tests are confirmatory and some suggest that disease. Confirmatory tests like bone marrow examination for typing of leukemia, hemoglobin to diagnose anemia, thyroid function test for diagnosis of hypo or hyperthyroidism, and Widal test to diagnose and treat fever. The second indication for lab tests is to help in the differential diagnosis. Lab tests help in the diagnosis of diseases like TLC in the case of acute appendicitis or other reason. Liver function test is ordered in order to find the type of jaundice. The next indication for lab tests is to know the prognosis. Lab tests help to know the progress of the disease, like erythrocyte sedimentation rate in the case of tuberculosis. Tumor markers prognostic in the treatment of cancers. Lab test is also indicated in order to monitor the treatment. Lab test has been found to help in the effectiveness of the treatment, like chemotherapy in ovarian cancer or renal function test in renal disease. International Normalized Ratio or INR can be used in the monitoring of the anticoagulant therapy. And finally, lab test is also indicated as a screening test. So these lab tests are done as panels for the diagnosis of disease in a community. For example, screening in the blood bank of donors. So this is to summarize the indication for lab tests. To confirm the diagnosis, for differential diagnosis, lab tests can be done for prognosis, for monitoring the disease, and also as a screening test. So how does lab testing work? The process for lab tests begins with the collection of a sample of blood, tissue, or other biological matter from the patient, which is then sent to the lab where it is uniquely identified and examined to make certain that it is appropriate for the testing ordered by the healthcare provider. Some tests are manually evaluated, while most are performed using technically advanced instrumentation. Once the testing is complete, the lab issues a report with the findings to the ordering clinician. When the healthcare provider receives and interprets the lab result, informed decision can be made as to most appropriate treatment for the patient. So this is the life cycle of a lab test. Yeah? The life cycle starts with the patient goes to see the doctor. Then the doctor will perform the examination, and based on the finding, the doctors will order a specific lab test. Yeah, specimen will be taken. This specimen will then send to the lab. The lab will perform some tests to analyze the specimen and will produce the results. The lab will then provide the result to the doctors. The doctor will then interpret the lab result. Then the doctor will inform the patient of the result and the implication. And finally, the doctor will come up with a diagnosis based on the examination and the lab test. And the doctor will finalize the treatment plan for the patient based on his diagnosis, his or her diagnosis. There are some questions that need to be asked before ordering a test. First, why is the test being ordered? Okay, second, what are the consequences of not ordering the test? Third, how good is the test in discriminating between health versus disease? Fourth, how are the test results interpreted? And finally, how will the test result influence between management and outcome of the case? So in establishing a diagnosis based on lab test result, there are certain principles that need to be followed. Uh, the principal approaches can be classified into four: hypothesis deduction, patient recognition, medical algorithm, and rifle versus shotgun approach. Hypothesis deduction. This involves establishing a differential diagnosis based on the patient's history, followed by the selection of tests that are the most likely to confirm diagnosis on the list of the differential diagnosis. Second principle is the pattern recognition. This involves comparing the patient's pattern of result for several lab tests or clinical findings that have been determined previously to provide excellent power in discriminating between various competing and or closely related diagnoses. For example, comparison of features or clinical features between epiglottitis and croup. In epiglottitis, coughing is uncommon, whereas coughing is common in croup. And in epiglottitis, patient will suffer of high-grade temperature, but in croup, patient will have low-grade temperature. So there is a comparison. Uh, so with this, we can use to perform a pattern recognition. The third principle is the use of medical algorithm, also known as decision trees. Medical algorithms are particularly important in establishing a diagnosis based in part on information obtained from ordering the most appropriate or necessary lab tests. Medical algorithms are logical and sequential. It maximizes a clinician efficiency and minimizes the ordering of unnecessary lab tests. Medical algorithm can be easily updated with improved strategies for diagnostic decision making as new and better tests becoming available. So those are the approaches, the principal approaches in uh, establishing establishing a diagnosis based on the result of the lab test. Talking about the lab test or the lab result, normal values of the lab test may vary from lab to lab depending on techniques and reagents used. Normal values may also vary depending on the patient's age, gender, weight, height, and other factors. Laboratory error is a fairly uncommon occurrence. However, it can happen. Potentially causes of lab error include technical error, improper calculation, inadequate specimen, incorrect sample timing, improper sample preservation, food substances affecting specimen, or medication interference with lab tests. If lab error is suspected, the test should be repeated. Now let us look at the most frequent ordered lab investigation in oral surgery. The first one is full blood count. The full blood count gives insight into the cellular components of blood, including white blood cell, red blood cell, and platelets, providing numerical values relating to this cell, meaning the amount of the cells, size, and the contents. These results provide vital clues to the presence of underlying pathology. A standard full blood count can be broken down into the following red cell, white cell, and platelet. Red cell tests include hemoglobin, hematocrit, mean corpuscular volume, red cell distribution width, red cell count, reticulocyte count, mean corpuscular hemoglobin, and mean corpuscular hemoglobin concentrate. White cell tests, on the other hand, include white blood cell count and white blood cell differential, whereas platelet tests include platelet count, mean platelet volume, and platelet distribution width. These are the normal values of the some of the parameters. For example, hemoglobin, okay, normal values 130 to 180 and 115 to 165 gram per liter. White cell count, uh, total normal total white cell count is between 3.6 to 11 times 10 power to 9 per liter. Neutrophil 1.8 to 7.5 power 10 power to 9. Lymphocyte 1 to 4 times 10 power to 9 per liter. Red cell count normal between 4.5 to 6.5 times 10 power to 9 per liter. Hematocrit between 0.4 to 0.54 per liter. Mean cell volume between 80 to 100 FL. Mean corpuscular hemoglobin between 27 to 32. And reticulocyte count between 0.2 to 2%. Red cell tests can quantify the amount of hemoglobin and red cells present in a sample. An abnormally low number of hemoglobin or red cell is known as anemia. An abnormally high number of hemoglobin or red cell is known as polycythemia. Red cell tests can also provide important insights into the underlying cause of anemia or polycythemia by looking at the average size of the cells and how much hemoglobin is contained within them. Mean corpuscular volume is a measure of the average size of the red cells present in the blood sample. This test is particularly useful in the context of anemia, where it can be used to aid the differential diagnosis of potentially underlying causes and guide which investigation to perform next. For example, microcytic, normocytic, and macrocytic anemia. Hematocrit is the percentage of the blood sample that is made up of red cells and tends to closely follow the trend of the hemoglobin level and the red cell count. Hematocrit can be affected by either the number of red blood cells or the volume of blood plasma. A raised hematocrit can result in increased blood viscosity due, due to being due to there being a high number of red cells relative to blood plasma, making the blood sticky. If the hematocrit continues to rise, hyperviscosity syndrome can develop, which is associated with the development of thrombus and symptoms such as headache, blurred vision, and chest pain. Red cell count is the number of red cells present per unit volume of blood. This test can be used in combination with the hemoglobin level and the hematocrit to confirm the presence of anemia or polycythemia. The causes of a high or low red cell counts are the same as those for hemoglobin and hematocrit. Now let's look at the white cell count. Leukocytosis, this is where we have a high white cell count. It can be caused by a wide range of pathological processes. It is important factors in determining the cause of leukocytosis include the rate of the white cell count rise and which type of white cells are raised. Common causes of acute leukocytosis include reactive, for example, infection, inflammation, post-surgery, steroid, the use of steroid, for example, stress response, that's meaning endogenous steroid which has been released, or due to medication, for example, exogenous steroid. And then the other cause of acute leukocytosis is hematological, for example, in the case of acute leukemia. Common causes of chronic leukocytosis include reactive, for example, in chronic infection or smoking, hematological disorder, for example, in leukemia or certain subtype of lymphoma, in the case of hyposplenism, and in pregnancy. Leukopenia is a low white cell count. This is caused by a wide range of pathological processes. Causes include infection. Uh, this can be seen as a transient phenomenon in viral illness or as a result of consumptions in sepsis. Leukopenia can also due to the use of medication, for example, antibiotics, immunosuppression, anti-epileptic, cytotoxic agent. And it can also due to deficiency in vitamin B12 and folate. Autoimmune disease also can cause leukopenia. Iron deficiency also may result in leukopenia. And HIV can also result in leukopenia. And the other cause of leukopenia is bone marrow failure. This is often seen alongside with low platelets and low hemoglobin. Okay, next we look at the platelet count. The platelet count is the number of platelets present per unit volume of blood. This can be high, known as thrombocytosis, or low, known as thrombocytopenia. Low platelet count. It means a reduced platelet count increases the risk of bleeding due to a reduced ability to form blood clots. So in a low platelet count, there will be a reduced platelet count which can increase the risk of bleeding due to a reduced ability to form blood clots. Clinical features of low platelet count or thrombocytopenia include mucosal bleeding, for example, in epistaxis or bleeding gum, and spontaneous bruising. The cause of low platelet count can be grouped into acute and chronic. The causes of acute thrombocytopenia include consumption, for example, in infection or bleeding, acute viral infection, the use of medication, for example, antibiotics, anti-epileptic, and cytotoxic agent. In certain hematological disorder, for example, disseminated intravascular coagulation and microangiopathic hemolytic anemia, for example, thrombotic thrombocytopenic purpura, and hemolytic uremic syndrome. Heparin-induced thrombocytopenia can also result in acute thrombocytopenia, and immune thrombocytopenic purpura also can result in thrombocytopenia. The causes of chronic thrombocytopenia include hypersplenism, cirrhosis, idiopathic thrombocytopenic purpura, the use of certain medication, for example, anti-epileptic, cytotoxic agent, autoimmune disease, vitamin B12, folate and iron deficiency, and bone marrow failure. Thrombocytosis is a condition where there is a rise in platelet count. The cause of thrombocytosis include reactive, for example, in inflammation or infection, myeloproliferative disorder, iron deficiency can also result in thrombocytosis, hyposplenism and postsplenectomy can also cause thrombocytosis, and underlying malignancy can also result in thrombocytosis. Okay, the next test is on coagulation profile test. The coagulation screening assesses the function of the clotting cascade and the body's ability to create a platelet plug. The main reason for performing a coagulation screen are to confirm a suspected coagulopathy, to monitor the coagulation status of a patient on long and short-term anticoagulant, to assess a patient's coagulation status prior to surgery, and to assess the synthetic function of the liver. Prothrombin time and international normalized ratio. These are one of the tests for to check the bleeding properties. The normal PT and INR is between 12 to 13 seconds and 0.8 to 1.2. The prothrombin time is a measure of the time taken for blood to clot via the extrinsic pathway. The international normalized ratio is a standardized version of this test, commonly used with patients on anticoagulants. Since the only factor in the pathway is factor 7, which is rarely deficient in isolation, these tests are a measure of overall clotting factor synthesis or consumption. The test can be affected by liver disease, disseminated intravascular coagulation, vitamin K deficiency, and warfarin level. Bleeding time, normal between 1 to 6 minutes. Bleeding time assess overall platelet function and levels. Platelet-specific disorder will increase the overall bleeding time. Example of these disorders are von Willebrand disease, Bennett-Solier syndrome, Glassman thrombasthenia, TTP, ITP, and disseminated intravascular coagulation, and thrombocytopenia. Thrombin time. This is the test of how fast fibrinogen is converted to fibrin by thrombin, normal between 10 to 15 seconds. In case of a prolonged time, the cause is either a synthetic issue or consumption issue. Similar to prolonged prothrombin time, this can be due to DIC, liver failure, malnutrition, abnormal fibrinolysis, and many other conditions. The next test is a liver function test. Liver function tests are among the most commonly ordered blood tests in both primary and secondary care. Liver function tests are requested for two primary reasons. First, to confirm a clinical suspicion of potentially liver injury or disease, and secondly, to distinguish between hepatocellular injury, meaning the hepatic jaundice, and the cholestasis, meaning post-hepatic or obstructive jaundice. Blood tests are used to assess liver function. The lab will be looking at the alanine transaminase, aspartate aminotransferase, alkaline phosphatase, gamma glutamyl transferase, bilirubin, albumin, and prothrombin time. These are the normal value of ALT and the rest. ALT normal value between 3 to 40, AST between 3 to 30, ALP between 30 to 100, GGT between 8 to 60, bilirubin 3 to 17, albumin between 35 to 50, and prothrombin time between 10 to 14 seconds. So when there is a liver function test derangement, the ALT will be increased in acute hepatocellular damage. The ALT will be normal or slightly increased in chronic hepatocellular damage, and ALT will be normal or slightly increased in cholestasis. The ALP and the GGT will be normal or slightly increased in acute hepatocellular damage and chronic hepatocellular damage, but ALP and GGT will be increased in cholestasis. Bilirubin can either be slightly or markedly increased in acute hepatocellular damage. It could be normal or slightly increased in chronic hepatocellular damage, and bilirubin can show a marked increase in cholestasis. The next lab test is renal profile. Renal profile is a test to assess kidney health. It is useful to measure kidney function. Renal profile gives information on levels of creatinine, sodium, calcium, chloride, blood urea, and potassium. Renal profile also indicates how well the kidneys are functioning. It is reflected by the parameters mentioned above. Renal profile is a monitoring tool for patients with chronic kidney disease. What is the clinical significance of renal profile? Creatinine. Serum creatinine is elevated when there is a significant reduction in the glomerular filtration rate or when urine elimination is obstructed. About 50% of kidney function must be lost before a rise in serum creatinine can be detected. Thus, serum creatinine is a late marker of acute kidney injury. Blood urea and nitrogen. or BUN is a serum urea or BUN level will be increased in acute and chronic renal disease. The EGFR equation are used to determine the presence of renal disease, the stage of chronic kidney disease, and to monitor response to treatment. So the other test that is performed during the renal function test is protein, is to check on the protein. Uh, Here is we're looking at the albumin, which is a protein that makes up about 60% of protein in the blood and has many roles such as keeping fluid from leaking out of blood vessels and transporting hormone, vitamin, drugs, and ion like calcium throughout the body. And the other thing we will be looking in the renal function test is the waste product. Uh, Urea is a nitrogen-containing waste product that forms from the metabolism of protein. It is released by the liver into the blood and is carried to the kidney, where it is filtered out of the blood and eliminated in the urine. Okay. Creatinine is the other waste product that is produced by the by the body's muscle, and almost all creatinine is eliminated by the kidney. So looking at the electrolyte, sodium. The normal value of sodium is between 135 to 147 millimole per liter. Increased sodium, or also known as hypernatremia, may result from increased sodium intake or increased fluid loss. Thus is the primary mechanism to prevent hypernatremia, and therefore hypernatremia usually occurs in individuals who are unable to obtain adequate fluid intake. Fluid loss may also result from gastroenteritis, diabetes insipidus, Cushing disease, hypoaldosteronism, and administration of hypertonic saline solution are causes of hypernatremia. Decreased sodium, or also known as hyponatremia, may be caused by a decrease in total body sodium, but is more commonly attributed to excess accumulation of body water, meaning dilutional hyponatremia. Common causes of dilutional hyponatremia include uh, chronic heart failure, cirrhosis, severe burn, chronic renal failure, and nephrotic syndrome. Sodium depletion may also be seen in syndrome of inappropriate antidiuretic hormone secretion, SIDH, cystic fibrosis, mineralocorticoid deficiency, or fluid replacement with solution that do not contain sodium. SIDH may be associated with disease states such as cancer or the use of medication, including chlorpropamide, thiazide diuretic, and carbamazepine. The second electrolyte that will be tested in renal function test is the potassium, and normal value between 3.5 to 5.2 millimole per liter. Causes of increased potassium, or also known as hyperkalemia, include metabolic or respiratory acidosis, renal failure, Addison disease, dehydration, and massive cell damage from burns, injuries, and surgery. The other cause of hyperkalemia include medication such as angiotensin enzyme converting inhibitor or ACE inhibitor, angiotensin receptor blocker, potassium supplement, potassium sparing diuretics, and oral contraceptives. The cause of decreased potassium or hypokalemia includes severe diarrhea and or vomiting, respiratory alkalosis, hyperaldosteronism, Cushing disease, alcoholism, and the use of amphotericin B or thiazide, loop, or osmotic diuretics. If a patient is hypokalemic and potassium supplement have not helped to correct the low potassium, check to see if the magnesium is also low. Decreased potassium is difficult to correct while the magnesium remains low. The next electrolyte in concern is chloride. Normal value between 95 to 106 millimole per liter. Increased chloride, or also known as hyperchloremia, may be seen in metabolic acidosis, respiratory alkalosis, dehydration, diabetes insipidus, eclampsia, and renal disorder. Decreased chloride or hypochloremia may be associated with prolonged vomiting, gastric suctioning, metabolic alkalosis, Addison disease, and the use of acid suppression, for example, H2 blocker and proton pump inhibitors. Blood urea nitrogen. Normal value between 2.1 to 7.1 millimole per liter. Urea nitrogen is an end product of protein catabolism. It is produced in the liver, transported in the blood, and cleared by the kidneys. BUN concentration serve as a marker of renal function. Increased blood urea nitrogen, also known as azotemia, may be associated with acute or chronic renal failure, chronic heart failure, gastrointestinal bleeding, high protein diet, and the use of nephrotoxic medication. Decrease in blood urea nitrogen is seen in liver failure because of inability of the liver to synthesize urea, and in disease states such as SIADH and acromegaly. The next element in renal function test that need to be observed is creatinine. Normal value between 50 to 115 micromole per liter. Muscle creatinine and phosphocreatine break down to form creatinine. Creatinine is released into the blood and excreted by the glomerular filtration in the kidney. An increase in serum creatinine in the face of unchanged creatinine formation suggests a diminished ability of the kidney to filter creatinine. Thus, serum creatinine is used as a tool to identify patients with renal dysfunction. The next laboratory test that we're going to discuss is the microbiology. The microbiological test involve the bacteriology test and the serology test. The bacteriology test include the cerebrospinal fluid culture and sensitivity, the blood culture and sensitivity, urine culture and sensitivity, pus culture and sensitivity, and nasal swab culture and sensitivity. Whereas serology tests include those hepatitis antigen tests, anti-hepatitis B, anti-hepatitis C, and HIV tests. The next lab test that is frequently ordered in oral surgery is the histopathology. This is the test to study tissue related to disease. A histopathology report describes the tissue that the pathologist has examined, or in other words, this is called a biopsy report. Uh, but it can identify features of what disease tissue looks like under the microscope. So a component of histopathological report should include a description of the appearance of the involved tissue, a diagnosis, a synoptic report detailing the finding of the case, and the pathologist. So the component of histopathology report should include a description of the appearance of the involved tissue, a diagnosis, a synoptic report detailing the finding of the case, and the pathologist. Next, we'll be looking at the legal aspect of lab tests. So the use of clinical lab tests has several legal ramifications. Because lab test is largely controlled by state law, healthcare provider must comply with the specific statutory provision that pertain to the ordering of tests. If patients present with a specific signs or symptoms indicative of systemic disease, healthcare provider should order the appropriate test so that the appropriate testing can be obtained. In ordering clinical lab tests to confirm a presumptive diagnosis, the healthcare provider will be held to a medical standard of care with respect to the interpretation of the result, the prompt communication of the result to the patient, and the reordering of the tests that have produced questionable or incorrect findings. Test results, communication with patient, and recalls and referral should be documented in the record of care. Lab, uh, in lab tests, involved can happen in three phases: the pre-analytical phase, the analytical phase, and the post-analytical. The pre-analytical error. The pre-analytical phase of the total lab test process is where the majority of lab error occur. The pre-analytical error can occur at the time of patient assessment. It can happen during the test order entry, or during the request completion, or during the patient identification, the taking of patient identification. It can also occur during the specimen collection, or during the specimen transport, or during the specimen receipt in the laboratory. So the common source of pre-analytical error are ordering tests of the wrong patient, ordering the wrong test, misidentifying the patient, choosing the inappropriate collection container, and labeling container improperly. So these are the type of error depending on the phase of total testing process. For the pre-analytical phase, the type of error include inappropriate test request, order entry error, misidentification of patient, container inappropriate, sample collection and transport inadequate, inadequate sample and anticoagulant volume ratio, insufficient sample volume, sorting and routing errors, and labeling error. And the rate of error is between 46 to 68.2%. For analytical phase, the type of error most commonly are due to equipment malfunction, sample mix-up or interference, undetected failure in quality control, and procedure has not been followed properly. So the rates of failure of error is between 7 to 13%. And the post-analytical phase, the most common error include failure in reporting, erroneous validation of analytical data, and improper data entry. So the rate of error ranges between 18.5 to 47%. So lab test is a science professionally conducted with rigorous statistical analysis, quality control, and extensive oversight. Medical testing is an important component in the diagnostic toolkit of a healthcare provider. However, it is most reliable when used in conjunction with other meaningful data collected in the diagnostic process, when appropriate questions are asked and answered, and when there is open communication between healthcare teams and the patient. So laboratory error is a fairly uncommon occurrence. However, it can happen. The potential causes of lab error may include technical error, improper calculation, inadequate specimen, incorrect sample timing, improper sample preservation, or due to medication interference with lab tests. It is important to remember that if lab error is suspected, the test should be repeated. And it is very important to remember that we must always treat the patient and not the laboratory value. That, I thank you.